So we kind of made this is, what was really geared towards the EMRs, what to do in the first 5 minutes that you guys get a call. So patient care starts before the call. This is, local knowledge has a lot to do with it. Once you get running calls, you'll come to realize that there's occasionally patients that we go to frequently, so you kind of already know of what to expect when you get there. You know, if they have aggressive dog, or, you know, hey, their stairs going in the house are really wobbly and unsafe. So we're kind of thinking of that as we go. Knowing how to get there, so kind of knowing your area. Now, we don't expect you to understand and memorize where every address is, but if you get on one of our groups, everybody has an app you can put on your phone that will automatically pinpoint it on a map for you. When I first came up here, I downloaded an offline Google Maps of the district. So even without Wi-Fi, I can just type an address in and it would at least get me there. But two, even before the page goes off, just going through your equipment, if you do carry a kit, kind of knowing where everything is. For example, if you carry a portable suction, knowing where it is before you need it, rather than having someone vomiting all over, and now you're trying to remember where in this bag we have it. So just kind of keeping up. If you haven't been on a call every week, just take 5 minutes and look through your equipment. Call comes in, so what's the nature of response? Now this is just kind of your initial, your page to a car accident. So a car accident kind of in our brain, we're thinking this is probably a trauma type call. Could it have been a medical event that led to an accident? Yeah. I'll use an example we've seen throughout my career. Someone has a seizure while they're driving, they get in a car over. So this is kind of a combination of a medical event that likely led to a trauma. But we're starting to get in our brain, you're starting to think, okay, this is a trauma, so I'm going through my kit, I'm thinking as I'm going bleeding control, cervical spine stabilization, just kind of we call it, at least I always called in an ambulance, we're pre-gaming on the way to a call. Your partner's talking, or I'm talking to myself, okay, if I need this, how do I do this? Again, just kind of mentally preparing yourself for the call. Stage versus direct, we touched on that a lot. 9 times out of 10, a page will come in for an address or a location and you go right there. Occasionally, law enforcement or dispatch will tell you, we want you to stage over here because there's something going on here that we're not sure if it's safe for you to go there yet. So they'll tell you to stage, and what we do with dispatch on the radio or phone is we talk to them and confirm that we're reporting to staging location. Even if it sounds, a kid unresponsive, that we want to get there and help, if they're telling us to stage, there's a good reason for that. Patient bias, I added that in. I could say an address right now and it's going to evoke emotion from the current responders. Chipper Drive, which, that's Prescott. But see, I'm getting a lot of noddings, right? So you can tend to, and I dealt with this a lot in my old organization, where you would hear an address, you would hear a call, we've been there many, many times, and already you're biased. This is, they're wasting resources, there's nothing wrong with them. And I will tell you, the frequent flyer can have a heart attack just like anybody else. So really removing that patient bias, and we have to go in with an open mind and truly assess the patient. Additional resources, that's just kind of part of that scene size up. So am I needing, fire department? I get a call for a house with, especially in the winter, red flags go up where you get, a family ill or someone unresponsive in a house. What's anyone want to take a guess on something that we would probably should red flag more so this time of year? Carbon monoxide. Is this a CO call? And do we have the proper equipment to go in? So if we're suspecting carbon monoxide, you can just tell dispatch, hey, can you page fire department that, and just, we have concern for carbon monoxide. And I can tell you up here in the district, all of the fire departments are more than happy You ask and they're gonna show up, of course. But that's an example of an additional resource. Two terms that you kind of want to get ingrained into your head that you're asking yourself, do I have the proper BSI, body substance isolation? So BSI seems safe. You'll hear that a lot when we're doing stations. We had spent a lot of time talking BSI. You know, for me, low-level BSI minimum is examination gloves and eyewear. We get into, you know, you walk in a door, someone's coughing, you know, we can back out. Hopefully you got a kid, or, you know, we can put a mask on them. But we want to protect them, protect ourselves, and I've dug into that quite a bit. I talk about 360. 360 is kind of making a circle around the scene, which isn't necessary for your chest pain or your single patient medical calls, but when we get a car accident or we go to a structure fire, it's very easy for even experienced people to get tunnel vision. We see people in a car, we see blood on their face, we want to go right to them. You need to be able to step back and on those scenes be able to do a complete walk around first, and what we're trying to do is to identify things that may make us impatient. So is there a power line on or near the car? Is there smoke coming from somewhere? Is that we're making a firefighters, fire officers, we do that when we arrive at a house fire. That before we take a hose line into a building, somebody has to walk around that whole building. We call it the 360, that we're trying to get a full picture before we engage potential life resources to it. Threatening patients, I overdose, and I've kind of talked about this quite a bit. Fortunately, it's not a super high risk up here in our district, although we can never write it off. So our area sees a lot of tourists, and those tourists come from areas where drugs are a problem. So when we start to see high tourists, we have an increased potential for things like drug overdoses and toxicology type responses. So they're always concerning. Even if we walk in, we get called for someone who passed out, you get 2-3 minutes into your assessment, you realize, oh, this is something, probably an overdose. We need law enforcement here now. And if you feel threatened, we leave. I think, was that a couple weeks ago, we talked about there was an ambulance in Wisconsin that got stolen from a crew by a naked guy. That was my old department.
With a patient inside.
There was a patient in the back. So they responded to one of the more austere neighborhoods in the city, which usually when we would go to an ambulance call, which we did frequently in this particular neighborhood, we would leave one guy out by the ambulance. Just because we were worried we'd come back and all our stuff would be gone. So they got the patient loaded, two paramedics in the back, starting their IV, doing the couple minutes before we leave to go to the hospital, and they heard the driver's door open on the ambulance. So one of the paramedics, senior medics, says, hey, I'm gonna go see what's going on. Hopped out, begins arguing with the naked man. The other medic, hearing this, goes to help his partner, and just as he's stepping out of the side door, the ambulance takes off. So, not so much for EMR, but I will tell you, this is something that's going through my head nonstop. What if I was the one medic in the back while my partner's confronting a guy and we started moving? And it wasn't my partner driving. Do I leave the patient and save myself, or do I stay with my patient? I don't have an answer for that. And I will tell you, in that case of the medic jumping out, that is a threat to their safety, and patient abandonment laws wouldn't apply at that point. But yeah, something I'm gonna dwell on for some time. Put myself in that scenario, and I can't come up. Kind of lastly, number of patients. So how many patients do we have? And what over here on the chart to the right is there's various levels of triage, which we'll cover later in the course. And we triage when we have more patients than we have providers. So I'm trying to think, you get a pontoon boat collides with a ski boat. So we end up, they're on the water, but they're coming ashore, we might have 8 trauma patients. That is a mass casualty patient. We have a limited number of ambulances to move people, so triaging is, we go through them quickly and we identify which ones need to go first and which ones can wait. And the 10-second triage is what we used on the SWAT team. It's a very, very modified, kind of quick version, and we'll dive into that later, but I just put it up there as an example. That is something we will teach you. And the EMR, very often if we show up on the ambulance, our Winchester staff is probably going to be taking more command roles for a mass casualty incident and really not involved with patient care, and we're going to be tasking EMRs. And the volunteers will be doing that triage and initial treatment while the full-time crews are kind of setting up. We have to set up this whole orchestra that's going to happen in the next 20 minutes. And if it's not set up correctly, the whole incident just goes downhill. So the good news is that with triage is our paramedic may hand you a bag and say, go triage, and there's a chart right there. So every patient, you go, okay, they are green. Next patient. This takes, it's pretty much, are they walking? If the answer is yes, they're priority 3, green, which is stable. If they're not walking, are they bleeding severely? If yes, can we put a tourniquet or pack the wound? If we can, then they're priority 1. If we can't, are they talking? And so it's just kind of a flow chart and takes us to get put into categories based on that. Providing a size up, and this really depends on your experience level, but a size up is something we typically give on a radio to incoming resources. So if you are first to arrive on scene, we're going to a car accident. You got law enforcement coming, you got ambulances coming, fire, rescue, you got a lot of people coming your way. And with our distances up here, the more information I can get coming in an ambulance, I can start to order additional resources as needed. So, you show up, it's a 1 vehicle rollover, there's 3 patients, 1 of them is unconscious, 2 of them are walking and talking. That paints me a beautiful picture. It's not rocket science, but it tells me I'm gonna need to get a 2nd and probably 3rd unit rolling. If you tell me we got 2 cars involved and they both need extrication, we're probably gonna be putting a request for a 2nd fire department. Winchester, you cut that car. Manny, you cut that car, as an example. So the quicker we can get resources coming, the better. Maybe a safety concern. Hey, we got a car rollover in the ditch. There's a power line or a wire on top of the car. Is it a cable wire? Is it a power wire? We don't know. And we ain't touching it till someone who does know can. Like I always tell the power company when they say the power's off, I'll say, okay, put your genital on that wire and then I'll say it's fire scenes, I don't want to dive into that, but you pretty much are just telling them what you see on the radio real quick over 5 minutes. So, we've got a house and there's fire and smoke. That's huge to the fire department, where I'm at the address and I'm not seeing nothing or nothing showing. That also paints a good picture. And I just put up here when I was doing the class, kind of let them go through, size up. The car accident, we have a vehicle on its roof in a ditch. Looks very significant damage. We don't see any patients at this time. I might, as I do a 360 and approach it, we've got 2 in the car unconscious or 1 outside the car. The one on the right, we're arriving on scene, looks like a patient in a snowbank. He doesn't appear to be moving, and 2 of his buddies are taking care of him. Again, paints a good, real quick, brief snapshot. And then I throw these in. So obviously the one on the left, we have a, whether how detailed you get, but we have a single story, what appears to be a single story residence with smoke and fire showing. And then the one on the right, power lines down. I try to find some spruce, balsam stuff like we got up here. And power lines down, we've got active fire in the woods. So sick or not sick? This is kind of when that first entry, and we had touched on this last week, so mental status, remember that AVPU? What does A stand for? Alert. V is they're responsive to verbal, P is they're responsive to pain, and then U, unresponsive. So how are they interacting? You know, if I walk in a room and they're looking at me and tracking me as I'm coming and acknowledging I'm walking in the room, they are alert. But if their eyes are closed and I have to yell their name or talk to them to get them to respond, then they're alert to verbal. And as we go down that, as we go from alert to verbal, verbal to painful, painful to unresponsive, the sickness of the patient increases. Skin color, and again, that's huge. And I kind of, sorry for the pictures, but the guy on the right, that's a really good example of that, pale diaphoretic. So you can see how he's really sweaty, skin is kind of pale, and of course the guy on the right, these are two different pictures, but the guy on the right looks like he's clutching his left chest, looks to be in significant distress. But if they're alert, you know, what's their chief complaint? Hey, I'm with the fire department, what's wrong? Just get their words, I can't breathe, my chest hurts. I think I have testicular torsion, whatever they come up with. I fell on the shampoo bottle in the shower, you know, standard. So we kind of elicit that, and then we're going to go right into kind of this rapid physical exam, which is that acronym MARCH, massive hemorrhage, airway, respiration, circulation, where bleeding, I'm looking for life-threatening bleeding. You know, if they've got some road rash, if they've got some small cuts where it's not actively coming out, I'm not worried about that. I'm worried about where you look at blood, it's actively flowing out. We don't have to dig in the weeds. If blood is actively flowing, just treat it quickly. Arm or leg tourniquet, anything else, get some pressure on. I put blood sweep in there. This is, especially if someone's unconscious, it's kind of dark, where if someone's laying on their, if you can imagine, I got someone laying on their back, and as I'm sweeping them for blood, you know, I go, you know, up around the neck, and I take my hands up and I look at my gloves. Up in the armpits, look at my gloves. I'm looking for, you know, I start centrally on the back of the head, look at my gloves, and then back of my gloves. I'm looking for areas of bleeding that's going to kill them quickly. When you're looking at like a potential gunshot. So, I mean, I could take a 45 caliber handgun. That's a pretty beefy bullet. And shoot, there's not going to be much blood. Has anyone ever seen or managed a gunshot? Okay, and a 45, even at this distance, there's a good chance it's not going to go through. And I can say this, I've seen enough of it. The hole is, well, I don't have a pen up here, but it's, you'll see a hole in the body about that big from a 45 caliber bullet, and maybe a little trickle of blood. So we're trying to identify those life threats, but if I just, you know, go through the body, then look at my gloves. I don't know where that blood came from. So that's kind of the blood sweep. Behind, look. Behind, look. Armpits, look. Every time I touch a body part, I'm looking at my gloves, and if I see blood, that's where I expose it quick, see where it's coming. Airway, you know, we'd spend some time on that. Is the airway open, and are they breathing? And if not, we work to correct that. So we open their airway, we suction, we bag it. If the airway and breathing is adequate, then we can move on to the next, and we look at the neck. And this is, I put this picture up, this is an example of that jugular vein distension. So you can really see how pronounced that is. That's super significant. Most people sitting up, you might see some, especially athletes, like me, but opposite, where you can see some, you know, kind of pronounced neck veins on them. But for the most part, people sitting up, we shouldn't have very visible neck veins. That visible neck veins, especially when they're sitting, basically what it means is the heart isn't emptying blood. There's a lot of reasons for it, and we'll get to that later in the course, but JVD is significant. And I didn't put it in here, but I like to check that trachea too. And I think I went through this, that you're kind of going up and over, and I'm just gonna see, does that windpipe stay center? And I'll grab it just enough for them to take one breath, and I'm just feeling if it moves on. A trachea shouldn't move when they're breathing. But that could indicate we got air pressure building up, they got a collapsed lung. Very, very concerning in mostly trauma patients, but we could see it in medical patients as well. I'm gonna expose the chest quickly, and I'm just looking for any massive trauma. Is it symmetrical? I'll listen right, listen left, and I just wanna know is air moving to the right, air moving to the left. I'll expose the belly, looking for any significant trauma. Now, a lot of the belly, I'll go as far to say like an evisceration, where we have bowel. That's super rare. You guys probably go I don't wanna freak you out, but you go probably your entire career and never see it. But if there is bowel out, number one, it's not that bloody. Number two, it's not immediately life-threatening. So we just put something over it so we don't have to look at it and keep going. That's not, although it looks bad, that's not gonna kill it. Okay. Pelvis, I'm just checking for, is it stable, or am I eliciting significant pain when I kind of compress it and push on it? And we'll practice that tonight. And then I'm gonna see, and I actually should have checked airway breathing. Do they have a pulse? When I meant about pulses down here, I'm just looking like, can I feel a pulse in their wrist? That tells me that their blood pressure is adequate. Arms and legs, if I would have seen massive bleeding, but I'm not gonna go through and physically look at them during this initial assessment. Don't worry about that, don't worry about that, don't worry about that. We talked about blood pressure last week, so after I kind of do that initial kind of rapid physical exam, now is when I move into, if I haven't gotten, I'm gonna try to get a baseline set of vital signs and try to get some kind of a history. Does anyone remember the acronym that we use to get our history? Starts with an S. Sample. So signs and symptoms, what we see and what the patient complains of, that's the S. A, are they allergic to anything? And, they might start rambling stuff off, well, I'm allergic to this, oh, okay. Does any of this make your throat swell up and you stop breathing? Because a lot of people say, well, I'm allergic to aspirin because I get an upset tummy. Well, we're not worried about that. That's a side effect, that's not an allergy. So I need to know, do you have a specific allergy to something that, number one, if I give it to you, you're gonna go into shock from it? Or could you have gotten into one of those that may be causing the symptoms that you have? Medications, now the one thing this can tie up 10 minutes of a conversation with a patient when they're going through their meds. So, we just say, do you take medicine, or do you take medicine right now on a regular basis for anything, or do you have a list, or where are they? And kind of generically, what do you take that medicine for? Your heart, I don't need to know I have prolapsed valve in my heart, I've got heart issues. Good enough. How's your lungs? How's your kidneys? Which kind of brings you into the P, past medical history. So what kind of conditions are you being treated by a doctor right now for? And you can almost check the boxes on stuff like, well, I have high cholesterol, I have hypertension, and that's just, like I found at the eye doctor this morning, my vision changed. I thought something was scary. The doctor said, welcome to turning 50. So, got that on. And we really just need to know, I don't need to know about your tonsillectomy when you were, 6. I need to know and a lot of times with patients when they start to go off, well, 20 years ago I had this, okay, we need to focus on things that are being treated right now. Then the L is kind of last oral intake, and honestly, we ask that because I want to know how full your belly is so I can be ready if you're going to throw up. And then E, what was going on when this happened? So the E stands for the events leading up to the chest pain, or, we go to an 82-year-old female that fell. Did you, talk me through your fall. And there's a big difference between Well, I was walking and the cat, I tripped on the cat, versus, I don't know, I was just walking to the living room and I woke up on the floor. That tells me that there may have been a medical event that preceded that fall. So, to do our best to get rid of that. So, that's kind of that part of the assessment, and then I would go into the more detailed, don't worry about that right now, or that. We may do a stroke assessment, where if the patient has concern for stroke. Has anyone ever heard of, I guess, I don't know, there's so many stroke scales, Cincinnati or BFAST, is that kind of the?
Yeah. BFAST, Cincinnati.
So BFAST is what, balance?
I use Cincinnati.
Hmm?
I use Cincinnati.
Yeah, me too. So there's stroke
I
scale,
don't for so many.
if the patient is concerned for stroke. So I see any vague medical complaint, and we're gonna talk about strokes later, is that we might wanna do a brief stroke scale, and kind of the big one is we look at arms, and they hold their arms up and smile, looking for facial symmetry, and then we'll have them repeat a sentence to us. You know, can they pronounce words? Do they sound like they're slurring? And when we get into medical emergencies in a few weeks, we're gonna really dive into the stroke scale. This may be where we wanna do a quick stroke assessment. Then we can go into more detailed stuff, and we'll go over the more full body exam here tonight. But please know that as an EMR, it's not the expectation that you get all this stuff done before the ambulance gets there. What I mean by that is you may arrive on scene and give a scene size up, and the ambulance is pulling out. That you haven't even, and the ambulance crew come up to you, what's going on? And you say, I don't know, you guys got here at the same time I did. Let's go find out together. Or the ambulance, you may be driving to the scene, you pull up and the ambulance is already there. Does that mean we turn around and go home? Absolutely not. That means you come in and say, hey guys, I'm here, what can I help with? And more than often, our guys are gonna go, thank God you're here. Could you help us with this? So, and I think that's kind of why they did that first responder term away, because you're not always the first ones on scene, but you are just as vital to the whole incident as whoever gets there first. Okay. That was kind of the rapid summary of that horrible PowerPoint that the textbook puts on. What time is it? Okay, this should be enough time. We'll watch this video. I'm going to watch it with you. I haven't seen it yet. And we will take a break, and we're going to break into some stations for the rest of the night. Well, I'm trying to think how I can, any tech people in here? I can't see it on my screen.
Yeah.
I can only see it here, but I can't get to the play. Oh, there we go. You know what? That's probably the problem right there.
Reports, but they're not. They're like words of a story that tells us what's going on inside the patient. The nature of our craft, the nature of EMS limits our diagnostic capabilities. We don't have access to the same information other healthcare providers would when they're trying to form their field impressions or diagnosis, or determine what treatment is best for the patient. So this makes vital signs especially valuable in the EMS setting. Now, before we dig into the 5 vital signs, heart rate, blood pressure, respiratory rate, temperature, and pulse ox, let's spend a little bit of time talking about how to read them. Now, each individual vital sign adds a little bit of value to the story. But just like one word pulled from a page in a book doesn't tell the story, one individual vital sign doesn't tell you everything that's going on in the patient. It needs to be associated with something like history or assessment finding or blood pressure. Let me give you one example. Let's say you have 2 patients, and both of these patients have an identical heart rate of 140. But what happens when we tie that heart rate to blood pressure? Well, patient number 1 has a blood pressure of 80/50. The heart rate falls outside of abnormal limits, but it's not the problem. A heart rate of 140 in this patient can be contributed to the body trying to maintain cardiac output. The heart is actually doing what it's supposed to do. Now, on the other hand, if we had a patient with a blood pressure of 190/110, well, now the heart rate is contributing to that hypertension. You see how we had 2 identical heart rates, but it wasn't until we associated them with another vital sign, in this situation, blood pressure, that we can start to determine a clear picture of what's going on inside the patient. So I think the story analogy is working, so let's keep it up. Some stories have multiple pages, and as you turn those pages, the story evolves and the characters change. Vital signs are the same way. One full set of vital signs can help you figure out if your patient is critical, but it won't help you figure out if the patient is stable. Now, I get it, critical and unstable are normally used interchangeably, but they are not the same thing. And I'm not pointing that out to pick on vocabulary. Knowing the difference can guide treatment and give you a more accurate mental image of the patient's overall condition. A critical patient is when some assessment finding, vital or diagnostic, is not compatible with life. Stability incorporates the dimension of time. In other words, is the patient's condition changing? Are they getting better? Are they staying the same? Are they getting worse? This gives you the ability to form an estimation of how long the non-critical patient will stay non-critical or the already critical patient will remain viable. Now that we understand each vital sign comes together like words and then sentences and they form this bigger story, let's talk about the individual vital signs. We can get a pulse anytime an artery finds itself between a firm surface and our fingertips. The 5 most common locations for us to find a pulse are the radial, carotid, brachial, femoral, and pedal pulse. Learning to get a pulse is normally the first vital sign we learn how to obtain. But we can get so hung up on the rate, it's easy to overlook what it's telling us. Now, all this isn't to say heart rate isn't important. The heart rate just needs to be tied to something else, like history or blood pressure. For example, if you were to pause this video, don't pause the video, but if you were to pause the video and ran as fast as you could for 5 minutes, your heart rate would probably be greater than 100. Can we really call that abnormal? Or is that your heart doing what it's supposed to do when our oxygen demand increases? So we had to tie the heart rate to your recent history of running. In this case, it was exercise. Now, sometimes an abnormal heart rate is a compensation mechanism, and other times it's associated with the root of the problem. And yet, other times still, it is the problem itself. But all those conditions require you to tie it to something like blood pressure, or in this case, history. Now, I know we've already done it earlier, but let's revisit some abnormal heart rates and combine them with patient complaints, history, or blood pressure, and use that to develop a solid field impression. Let's say you had a patient with a heart rate of 40, but a blood pressure of 220/70. We obviously don't have a perfusion problem, but we can all agree that heart rate is lower than normal. But the heart rate, again, is not the problem. This is an indication that the patient has some kind of intracranial pressure going on, likely from a traumatic brain injury or hemorrhagic stroke. It would all depend on the patient's complaint and their
I wouldn't expect
presentation
you
and
guys
their
to know
history.
that.
But any attempt to fix that bradycardic heart rate is going to make the patient's condition deteriorate. Now, sometimes it's a compensation mechanism, like we talked about before. If you had a patient with a heart rate of 130, but a blood pressure of 110/70, they have a shock index of greater than 1. For those of you that don't know, a shock index is when your heart rate is greater than your systolic pressure. In this case, we have a heart rate of 130, but a systolic pressure of 110. Ever we have a shock index of greater than 1, it's an indication that there's a chronotropic compensation mechanism that's driving that tachycardia. Or in other words, the patient.
Okay, I do want to explain that. So shock index is, like I use it, it's a real kind of shoot from the hip, tell you that the body's trying to compensate for something that's going on. So if I'm bleeding internally, I'm in a car accident, snowmobile accident, I have blunt trauma, hit a tree to, let's just say my kind of right belly. And we do the exam, you lift the shirt. We don't see much, you know, because the accident just happened 10 minutes ago. It might be a little reddened, but you just barely touch that side and oh, they got pain kind of right over here. Does anyone remember what might be under here on the right side? The liver. The liver is a solid organ full of blood vessels. So a blunt trauma to that can tear it. And what happens when you tear a solid organ? It bleeds. So I'm bleeding internally. You may not see any external evidence, but you check my first blood pressure and it's 90/40. I've got, you can feel a pulse in the wrist, but you got to dig for it a little bit. And my pulse is 88. So what was my systolic blood pressure, the top number? 90. My heart rate was 88, so I have a negative shock index. My systolic blood pressure is still higher than my heart rate. Now, 5 minutes later, we recheck. Now my blood pressure is 88/42, and my heart rate's now 110. Where now my heart rate is gone above my systolic blood pressure. So now I have a shock index that's higher, right? So I can divide my heart rate by my systolic and get positive number. But what's happening is because I'm bleeding, I can't generate the pressure because I'm losing that fluid. So my body compensates by trying to speed the heart rate up to try to maintain that pressure. Because pressure, a generic term is cardiac output, and cardiac output is attained by heart rate times stroke volume. And stroke volume is the amount of blood that my heart pumps with each beat. So if I'm losing blood, I don't have the volume to pump. So what do I do to increase my cardiac output? I have to increase the heart rate. And so your body can fix it until eventually your heart rate keeps going up and up and up, and we just don't have enough fluid to pump. So then our cardiac output, we kind of hit that curve where they start to go down. Have you ever heard of the patients crashing? Like, just watch a medical drama. Patients crashing, that's what they mean, is that they were holding, and now the vital signs are dropping off and we're behind the 8 ball.
His heart rate is increasing to maintain blood pressure. The heart's doing what it's supposed to do, and if we looked at just the heart rate and identified that abnormal heart rate as the problem, we wouldn't be able to flush out the field impression of hypovolemic shock. You combine that with other findings with that heart rate, that blood pressure, and you attach the skin, the history, the assessment, you start to develop that field impression. But again, we lose that if we're just looking at a heart rate of 130 as the problem. Now, sometimes the heart rate itself is the problem. If you approach the patient and they had a heart rate of 40, just like the earlier patient, but a blood pressure of 60/30, well, that is a heart rate problem. But all these heart rates we just talked about need to be attached to history, blood pressure, other vitals, other assessment findings to flush out the meaning, the cause, and the origin. And identifying the heart rate as a symptom or the heart rate as a problem. Now, let's talk about some other things that we can take away from the simple act of checking a pulse. Now, obviously, the presence of a pulse is always important, but where we're getting that pulse from matters too. For example, if you have a patient with a broken extremity, in this example, it's going to be the leg, we got to make sure that any kind of internal injuries didn't compromise the artery. If your patient had a femur fracture and it ruptured that femoral artery, aside from the hypovolemic shock, we have to worry about the tissue distal to that injury. So this patient has a higher priority than just a patient with a fracture. So make sure we're checking distal pulses when we have an injury to the extremity. Now, there's still information we can get from a pulse, and one thing that's so often overlooked by EMS providers is the quality of the pulse. A bounding pulse can indicate hypertension, and a weak pulse can indicate hypotension or vasoconstriction. In other words, if the patient has a thready pulse and a normal blood pressure, the body's using vasoconstriction to maintain perfusion. Again, we see that combining vitals can give us a clear picture of what's going on. So there's one last thing I want to talk about, and I want you to consider when you're checking a patient's pulse. If the pulse becomes weak when they take in a breath, this is a condition called pulseless paradoxis. What causes that change in strength and regularity in the pulse is the lungs are crushing the heart. This can be caused by several different conditions. Severe asthma with air trapping, it can be caused by tension pneumo, it can be caused by cardiac tamponade, but they all have one thing in common. There's this increased interthoracic pressure that is crushing the heart, and that's going to change the heart rate and the strength or quality of the pulse when you're feeling for the patient's pulse. So make sure we're checking through a full respiratory cycle. The other thing we want to consider is the regularity of the heart aside from pulseless paradoxis. Now, if it's not associated with the respiratory system and there's any kind of irregularity, it's probably an EKG issue. And it's noteworthy whether it's irregular or regular, or if it's regular or regular. So is there no rhyme or reason to that pulse? Or is the pulse not completely regular, but there is a pattern? Now that we see how much information we can get from the simple act of checking a pulse, let's move on to the next vital sign and see what we can get there. So we're going to tackle blood pressure now. Now, we all know that the cells of the body need oxygen and they need blood glucose. We know that that oxygen is carried on the red blood cells and the glucose is in the blood. But blood pressure is what gets that blood, oxygen, and glucose to the cells. And then after they use that oxygen and glucose, it's what helps get the waste away from the cells. Now, blood pressure is created when the heart contracts. When the heart contracts, a pressure wave travels through the circulatory system. That's what we document as systolic pressure. And then when the heart's relaxing, the residual pressure left in the circulatory system is what we document as the diastolic pressure. Now, the contraction of the heart does create this pressure, but it's not the only thing that affects it. The amount of blood we have and the size of our blood vessels also affect the blood pressure. Now, I know most people watching this probably already know how to get a blood pressure, but we're going to go over it in a little bit more depth. We're going to put a different spin on it than you've probably heard before. Just like we said before, every time the heart contracts, the blood flow puts an outward pressure on the arteries. For the sake of this video, we're going to say that the patient has a blood pressure of 120/80. The pressure on these walls is 120, and then in between beats, it's 80. Now, when people are learning how to get a blood pressure, they're often told to listen for the pulse, but that's not entirely accurate. Why do I say that? Well, if you put a stethoscope in the same place you would when you were trying to get a blood pressure, but you didn't have a blood pressure cuff on the patient, you wouldn't hear the pulse. But the patient has a pulse. So if it was truly a pulse you were hearing, you would hear it all the time, and we wouldn't be able to get diastolic pressure the way we do. Now, different people have different recommendations on what you should start your blood pressure cuff at. 180 is a good number, but you're basically just trying to get a pressure that's greater than your systolic pressure. So we'll use 180 as an example. When you inflate the blood pressure cuff to 180, it's greater than both the 120 and the 80, so the artery collapses. There's no blood flow, and then you start lowering it. Even all the way down to 130, the blood pressure cuff is putting more pressure on the artery than the circulatory system is. So your artery remains collapsed. There's no blood flow. But once you cross that threshold of 120, what happens? Well, as that systolic pressure wave comes through, that 120 is greater than 118, so the artery opens up. But in between beats, what's going to happen? Well, the pressure is going to drop back down to 80, and that artery is going to collapse again. This is what you're hearing. You're not hearing a pulse, you're hearing that artery open and slam shut, open and slam shut. Then you continue to lower the pressure in the blood pressure cuff, and then once you get below the diastolic pressure, the artery remains open, so you stop hearing that pulsating sound. Now there's another method of getting a blood pressure without a stethoscope. Now you can only get the systolic pressure with this method, but it's great for noisy environments or when you're in a hurry, and that's feeling the patient's radial pulse. So you apply the blood pressure cuff, you increase it to a number greater than the systolic, go ahead and use that 180, and you attempt to find the radial pulse. As you release air from the blood pressure cuff, you're gonna eventually regain that radial pulse. Whatever the pressure was in the blood pressure cuff, when you regain the radial pulse, is the systolic pressure. You would document that as, in this case, 120 over P. A full blood pressure is always preferred, but there's some times in some situations where this is the only option you have. And knowing the patient's systolic pressure is better than not knowing their pressure at all. Now, before we move on from blood pressure, I want to talk about MAP. Some students struggle to memorize the formula, and then other students that memorize the formula don't really understand what MAP is. And we're going to use one of those old school math problems you used to get in elementary school to kind of conceptualize and explain what's going on. Let's say we had 3 friends, Tyler, Sam, and Brian, and they all decide to go to the casino, but beforehand, they make an agreement that they're going to split their winnings evenly. When they come out of the casino, Tyler has $120 and both Brian and Sam have $80. So they put it all on a table and it comes out to $280. Now, they agreed to split it evenly 3 ways. So they divide that $280 by 3 and they end up with $93 a person. So the average between them was $93. That's what MAP is. Just take away the dollars. So we have a high pressure, the systolic pressure. This is the pressure in the vessels when the heart's contracting. And then we have a lower pressure, the diastolic pressure, the pressure in the blood vessels when the heart's relaxing. But we stay in the diastolic phase longer than we do the systolic phase. So since we're in the diastolic phase longer, we measure it twice. So to figure out a patient's MAP, you add the systolic plus the diastolic plus the diastolic, and then you divide that number by 3, and that will give you the patient's MAP. This is such a better way to measure the patient's perfusion status than just focusing on the systolic, because there's still perfusion going on during the diastolic phase. And if we're just focused on the systolic, we miss that. But when we measure the patient's perfusion status using MAP, we're taking into account both the systolic and the diastolic. Now let's move on to respiration. Most of the people watching this know that a normal respiratory rate is between 12 and 20. There's more to the story. You need to consider things like work of breathing, the depth, the lung sounds. All of these things are just as, and possibly even more important than the rate itself. So let's start with the work of breathing. This is an assessment that can be conducted while you approach the patient, otherwise known as the general impression. Is the patient working to breathe? We're so used to people breathing that we generally don't notice it until something's abnormal. But anytime a patient is working to breathe, we should be asking ourselves why. Breathing should be almost effortless, regardless of the rate. And yes, that means if they're working to breathe and their rate is 16 a minute, that's still abnormal. So measuring just the amount of times they're breathing isn't enough. It needs to be associated with that work of breathing, their lung sounds, and the depth of breathing. If a patient's working to breathe, it's likely going to guide our field impression and our treatments. The absence or presence of labored breathing should also be documented on our PCR. While it's obvious to us, it won't be obvious to the person reading the PCR. Let's talk about the depth of breathing. This is one that we tend to overlook when we're assessing the respiratory system. Now, to understand this, we're going to have to review tidal volume and minute volume. So let's start with tidal volume. An exact measurement of tidal volume, an accurate measurement of tidal volume is 5 to 7 milliliters per kilogram of ideal body weight. Now, most EMT and advanced EMT tests, including National Registry, will give you a generic number of 500 milliliters. That means that the patient breathes in, on average, about 500 milliliters per breath. That is called tidal volume. Every time they breathe, they're breathing in 500 milliliters or breathing out 500 milliliters. So if we had a tidal volume of 500 and a respiratory rate of 12, we would know that that patient's breathing about 6,000 milliliters a minute. So if we multiply their tidal volume times the amount of times a minute they're breathing, we can figure out how much air they're moving over the course of a minute. That's minute volume. So if they're breathing 12 times a minute and 500 milliliters per breath, that's 6,000 milliliters per minute of minute volume. Now, why do you need to know this? Well, we're typically not measuring exact tidal volume in the field, but conceptually we kind of are. We might not be able to attach an exact number to it, but acknowledging and looking for deep, normal, or shallow breathing is important when we're considering what the patient's respiratory rate is. Let's say you had a patient and they were taking nice deep breaths and they were breathing about 10 times a minute and each breath was about 700 milliliters. Well, their minute volume would be 7,000 milliliters. Now, if you just looked at the rate of 10, you might say that the patient's breathing too slow. But when we look at it this way, we understand that that patient's moving more air than the patient breathing 12 times a minute. Now let's go the other way. Say you have a patient with a respiratory rate of 12, but the breaths are kind of shallow, and let's say their tidal volume is 300. If you multiply that 12 times a minute times those 300 milliliters, you end up with 3,600 milliliters. Now I want you to look at this. Before we explain minute volume, if we asked which patient wasn't moving enough air, you'd have probably said 10. But when we take into account tidal volume with our respiratory rate, we see that the patient breathing 10 times a minute is moving just enough air. Meanwhile, the patient that's considered within normal rates is actually not moving enough air because they're breathing shallow. So assessing the depth of the breathing is just as or even more important than determining the exact rate. Because we found here in this example,
And I just want to pause it here to reiterate, again, we are not asking any, paramedics included, to estimate actual volumes of air. But to put it in perspective, the 6,000 minute volume, kind of think that's normal. That's breathing 12 times a minute, normal volumes at 500 mLs per breath. But let's put it into something we can see up here. And actually a case we had up here last winter. Snowmobile accident, whether it was the handlebars, a tree, don't know, multiple rib fractures, okay? So a rib fracture, even 4 or 5 rib fractures, you're not gonna bleed out. If you didn't rupture your lung, you're not gonna collapse your lung. But we've got all these rib fractures, right, that in amongst themselves, not really immediately lethal. Has anyone ever had a rib fracture or a rib bruise or injury? It hurts to take a breath. And you don't want to, and one of the actions that we breathe is our chest has to move with breath. So we end up taking shallower breaths. And when we're doing shallower breaths, we're moving much less volumes. So we take that over 30, 40 minutes. Now tidal volumes, our rate's gonna go up to try to compensate that, but just because we're breathing more times a minute, we're still not getting the volume. So we are slowly going into respiratory failure. That these trauma patients, when they're taking those short, shallow breaths and their oxygen saturations are, let's say, 100%, we're probably gonna put them on oxygen if they have significant chest trauma and breathing shallow, because this person is going to deteriorate. Their sats are gonna hold 100%, 96, 90, 80. They'll start crashing because they physically can't take those deep breaths. So those are one where we're gonna start putting high flow oxygen on them right away, knowing that we're probably gonna have to intubate this person, put a breathing tube in. Not, for the EMR, but I'm just kind of putting in perspective that we can certainly see these patients, you can anticipate that if we're not moving enough volumes, they can only do that for so long. And so if someone's got a SAT of 98 and the medic says, put them on a non-rebreather mask, and you say, but their SAT's at 98, good. There's a reason that, because when we give them medicine to paralyze them, we need to build up this big oxygen cushion, because it might take us a few minutes to get that breathing. So just trying to put it in perspective for you.
Well, that the patient with a normal respiratory rate is gonna need positive pressure ventilation. And we wouldn't have got there if we were just looking at the rate alone. The last thing we're gonna cover in the respiratory system are lung sounds, which these deserve a video all on their own, but right now we're just gonna barely touch on them. But basically what we're trying to do when we're listening to lung sounds is develop a mental picture of what's going on inside the patient's lungs. We don't wanna find ourselves in that situation where we're trying to memorize certain lung sounds and associate them with certain conditions. When you hear rales or wheezing, you want it to generate a picture. We know that if the patient's wheezing, we have some bronchial constriction going on. We know if they have rales, we have small amounts of liquid that are in the alveoli. We know that if we hear coarse bronchi, that the patient has fluid in the bronchioles. And we know if we hear stridor, the patient has an upper airway obstruction. All these things should cue you for what's going on inside the patient. When you're listening to the lung sounds of a patient with rales, understand that there's small amounts of fluid in the alveoli, and then ask yourself, why is that fluid there? A lot of students have a hard time memorizing all the lung sounds because they're just trying to memorize them rather than visualize them. And unfortunately, we can't open up the patient's lungs and take a look, at least not without a lot of paperwork. We need to rely on our assessment findings. Now, while we're on the topic of respirations, let's jump over to another vital sign, pulse ox. So now we're going to talk about pulse ox, and it is a great tool, but so is a screwdriver. And just like a screwdriver, its value is only really seen when it's used for its intended purpose. So how does a pulse ox work? Pulse ox works by shooting a beam of light through the capillary beds, and there's a receptor on the other end of the pulse ox. The more light that makes it through the pulse ox, the lower amount of hemoglobin saturation the patient has. So if the red blood cells are packed with oxygen, very little bit of that light actually makes it through. And if there's less oxygen, more of the light makes it through, so you have a lower pulse ox. Now this is great at determining the amount of oxygen that's crossing from the alveoli to the pulmonary capillaries. It's also helping you titrate oxygen administration in your patients. But the percentage that the pulse ox is showing is not more valuable than your patient presentation. If the patient is struggling to breathe, they probably need supplemental oxygen, regardless of what the pulse ox says. It's also not a good tool for monitoring ventilatory status. A patient could stop breathing for a significant and life-threatening amount of time before you saw any drop in the pulse ox. Waveform capnography would be a much better tool for that, but capnography isn't something we're going to talk about in this video, maybe in a future video. Another weakness of the pulse ox is it monitors red blood cell saturation. So unless your pulse ox is designed to detect carbon monoxide, it can be fooled. And it does this because carbon monoxide binds the red blood cells the same way, but stronger than oxygen. So the light from the pulse ox gets absorbed by the red blood cell and gives you a false reading. Lastly, the pulse should always be felt and counted manually. Poor perfusion, cold environments, extreme heart rates, high or low can all result in inaccurate data from the pulse ox. So when is it valuable? Well, like I said earlier, to titrate oxygen, to help you determine if a patient's hypoxic, but only if it matches the patient's conditions. If your patient's working to breathe with a good pulse ox, treat the patient, not the monitor. And I know that's cliche, but this is the situation where it applies. The pulse ox is a great tool, but it's meant to supplement our assessment, not replace it. We're finally there, the fifth vital sign that we're going to talk about, temperature. Now, most EMS providers don't get temperature on every single patient they encounter. So for this part of the video, we're also going to add in the bonus of skin assessment. Skin as a whole is one of the most valuable assessment techniques we can have in developing solid field impressions, yet somehow it is so often overlooked. Towards the end of my EMT, advanced EMT, and paramedic classes, we play a game that's designed to help the students hone their ability to develop rock-solid field impression. They're all given a list of 64 medical conditions that they're likely to encounter in EMS. I pick one of those conditions off that list, and I don't tell them which one it is. They have to figure it out based off of 3 assessment questions. Those can be vitals, they can be history, they can be chief complaint, but they only get 3 questions to figure out which condition I picked. Time and time again, the students, without me saying a word, come to the same conclusion. There's 2 assessment techniques that will either rule out or confirm or help confirm every condition on that list. And it's lung sounds, and you guessed it, skin assessment. Skin temp, color, and condition should not be limited to patients with a possible infection or suffering from environmental emergencies. Now, don't get me wrong, temperature in these patients, very important. It establishes a baseline, helps you determine the severity, helps you understand if the patient's improving, getting worse. And everybody watching this video knows that a normal body temperature is 98.6 degrees Fahrenheit or 37 degrees Celsius. But the accuracy of that temperature depends on the method you use. There's axillary, which is basically the skin temperature or under the armpit. And then there's core temperature. So why is core temperature so important? Well, let's use a steak as an example. If you have a frozen steak on the surface of the grill, the steak will get hot. We don't check on the surface of the steak, we check the core of the steak. Well, in the human body, that's where the vital organs are. Hot or cold skin itself isn't what's causing the patient any kind of injury or harm. It's that core temperature in the vitals that's causing the problem. Depending on the circumstances, we can have drastic differences between the patient's core temperature and the patient's surface temperature. The color and the condition of the skin can tell you a lot about what's going on inside the system. Now, warm, flushed skin could be a natural response in the body just sending extra blood to the skin to help radiate some of that heat away. But can also be an indication of things like distributive shock, anaphylaxis, sepsis, neurogenic, anything where we have a vasodilatory problem. Cool skin can be environmental as well. In rare cases, it can be a sign of an infection. Not every patient with an infection has a fever. Some patients, albeit rare, but some patients actually develop hypothermia. But cool, clammy skin should tell you something about what's going on in the body too. The body is borrowing from its favorite blood bank, the skin. And as we approach that patient and we find that they're cool and clammy, the first question in mind should be, why is the body borrowing blood from the skin? Something's going on. Then we also have cyanotic skin, and that's where there's just not enough oxygen in the blood. The ratio of hemoglobin that's not bound with oxygen creates a bluish skin, which indicates the patient's low on oxygen and probably hypoxic. All these things we can get just from the temperature, texture, and color of the skin. If you merge your skin assessment with your other assessment findings and your vital signs, a field impression starts to emerge from this list of signs and symptoms. That's because in this video, you learn that each vital sign is like a piece of a puzzle. While each piece plays its role and has value, it takes multiple pieces to form a bigger picture or a field impression. I really enjoyed making this video with you. There's something satisfying about digging into the basic skills that we do every day and looking for information that we didn't know. It's going to make us all better providers. And until next time, be safe.
Okay, good. All right, I know it threw a lot at you that we really haven't necessarily covered yet, but we'll just continue to build on it. So go ahead and take a break. We will kind of get reset with some equipment, and I'll put some, probably just put tables away. We won't need to sit down anymore.